All right, I think we've got everybody. Yeah, so I thank you everybody for coming, and I'm going to hand over to our host, Sarah Hogan.
Thanks, Anna. I am assuming you can hear me loud and clear. Great. Kia ora koutou katoa. Welcome to our webinar on the global ADHD medication shortages. We really appreciate everyone taking the time to join us tonight. I'm Sarah Hogan and I'm an ADHD New Zealand board member, and I'm going to do just leading you through the questions that we have tonight. We're going to be recording this session, and closed captioning is available for those who need it, and we'll share a copy of the recording with you after the session. So before captioning and putting it up on our YouTube channel. So I think that means we are recording now. Little nod. Yep, we are recording now. Right, the current supply issues with methylphenidate ADHD medication impact a huge number of New Zealanders, which is why we've brought together a panel of experts, from those working to address the shortages nationally to professionals supporting people with ADHD and their whānau. The questions we're going to be asking tonight focus on the global methylphenidate shortage, what's being done to manage it, and practical steps that might help if you're dealing with some of those issues. So these have been gathered from the ADHD community through our Ask Pharmac project. The last 10 minutes of the session will be open to extra audience questions, and you can share those through the chat function at any time. And we'll do our best to get to as many of those as possible. But if we don't get to your question and you've posted something important, that's fine, because we might need to approach another agency, and that might be a reason why it doesn't get answered. So it might be something that's best directed to MedSafe or the Ministry of Health, for example, and we will gather that information for you, and we will get those answers and share those. We also have some breaking news tonight. So Pharmac announced this afternoon that it will be funding an additional brand of methylphenidate for people with ADHD from the 1st of December. And we'll be, excuse me, hearing a little bit about them as I introduce the panelists. And I know that a lot of people have been expecting this and have probably provided some feedback on the consultation. So you'll be happy to hear some news on that. So panelists that we have with us this evening, first up is David Hughes. David is Pharmac's Chief Medical Officer. He's the senior leader supporting the supply issue management and the cross-sector work. David, would you like to give us a quick rundown on tonight's announcement or today's announcement before I run through the other panelists?
You're very kind, Sarah. Yes, kia ora koutou katoa, ko David Hughes tokunga. And yes, Pharmac's very pleased to announce the decision to fund a new brand of methylphenidate. Methylphenidate Sandoz XR will be funded from the 1st of December 2025. It's an extended release preparation of methylphenidate. The other extended release medicines such as Concerta and methylphenidate Tiva will remain available. This new medicine comes in the 18 milligram, 27 milligram, 36 milligram, 54 milligram strengths. These are obviously the same strengths as Concerta and Tiva ER. This methylphenidate Sandoz XR, they make them really great names, don't they? Will have the same special authority criteria as Ritalin, Rubifen SR, and methylphenidate Tiva. For those who love numbers, that's special authority number 2411, and this means that it will be funded as a first-line treatment option for people with ADHD. A big shout out to Ashley Kleinsman from Pharmac. I'm sure she's on the line, for all her hard work getting this extra supply across the line. Back to you, Sarah.
Yeah, sounds like great news, and I'm sure we'll have some questions about that tonight. So the next panelist is Marinda Van Zel Green. She's Pharmac's supply chain team lead, and she's been supporting managing the supply chain challenges. So Marinda, are you on the line?
I am on the line. Thank you, Sarah. Kia ora
Excellent.
koutou. I'm Marinda Van Zel Green.
Thank you.
Thank you.
And then we have David Chin. David is a child and adolescent psychiatrist at the Infant, Child, Adolescent and Family Service based in Hutt Valley Mental Health Addiction and Intellectual Disability Service, otherwise known as MHADS. He's also an affiliate researcher and clinical senior lecturer at the Department of Psychological Medicine at the University of Otago. Welcome, David.
Kia ora koutou. Good to be with you all this evening. Thanks all for joining.
Thank you. And Then we have David Kadaya. David is a psychiatrist and clinical director of wellness support at Tamaki Health. Welcome, David.
Good, Koto. Thanks for the invite. Lovely to be here with you all.
And finally, not least, we have Kyra Sycamore. Kyra is a specialist mental health pharmacist in Christchurch, and she works with several national mental health groups. Are you there, Kyra?
I am. Kia ora, everyone. Yeah, so I'm the pharmacist on the panel, so hopefully we can answer people's trickier medicines questions.
Fantastic. So big welcome to all of you, and thank you so much for taking your time to share your knowledge with the community. So before launching into the questions, I just want to clarify that our panelists can't give individual medical advice or legal interpretations. So for personal care, please talk to your prescriber. So the conversation that we're having tonight is really just a general one. It's a general one about the issues and what's being done in New Zealand to deal with the shortages. And to our panelists, I'm going to ask that we do our best to keep the answers to an ADHD-friendly length as well. Right. So with that, I'll go to the first question that we gathered from the community. It is, why is there a shortage of ADHD medicines, and why can't we make them in New Zealand? Can we go to Mirinda for this one?
Yes, happy to talk on this, Sarah. Thank you. This has been a really complex problem, and we recognize that it's impacted a lot of people in New Zealand and continues to impact not only patients on it, but also the clinicians and pharmacists who look after those patients. We've seen a significant increase in demand for methylphenidate, and that's not just for the finished products, but also for the raw material that the product is being made of. Production has increased globally to try and meet that demand, because it's not just in New Zealand, it's felt in other countries as well, like the UK and Australia. And the manufacturers try and meet that demand, which is not easy. And our team at Pharmac are trying to get as much as possible of methylphenidate products, like you've just talked about now with a new brand for New Zealanders. As to the question of why can't we make it here, methylphenidate is a medicine that has, we call it a controlled medicine. That means there is import and export permits involved to import it into New Zealand and to export it out of another country that where it's being made at. There is limit in what can be exported. And then there is a higher level of regulatory requirement for those types of medicines. So that also means that if you want to put a facility up, a manufacturer in New Zealand, it's going to take a long, long time. There's a lot of regulations that need to be met, and it's going to take many, many years for New Zealand to be manufacturing this product. And just for everyone's information, Pharmac doesn't manufacture medicine. We fund medicine that's registered in New Zealand that's safe for people to use.
Great answer, Mirinda. Thank you. Does anyone else have anything to add on this issue? Okay, we might move on to the next question then. And I know this is one that has bothered a lot of people as they've been running around trying to get hold of their medication and failing repeatedly. Going on the Pharmac website, sometimes it says there is stock of the medication available, but people can't get their hands on it. Why is that? David
Yeah,
Hughes.
look, first of all, Sarah, I do want to acknowledge that there are 3 Davids on the panel. So in situations like this, I'm very happy for you to call me Hughesy. I'm not sure Dr. Chin would like to be called Chinny, but
Chinny's fine.
Thank you, Chinny. Yes, so as Mirinda said, we're trying all these things to meet the challenges of the supply issues, and certainly, and again, listening to you this afternoon, Sarah, on a previous meeting, you know, we really do want to acknowledge how challenging these issues are for patients and whānau. We're working as closely as we can with suppliers and with healthcare professionals and pharmacists to monitor the stock and to plan ahead. And we try to be as transparent as we can sharing the stock levels on our website and ensuring that those stock levels are updated frequently. And we know that this doesn't always match patients and pharma experience at the local pharmacy, and that's because our website is around what stock is available at the supplier. So we get this information from the multiple suppliers. However, there's no national wholesaler or real-time retail pharmacy stock system. So indeed, where the supplier may see that there is, from their perspective, stock in the system, at the individual pharmacies, that stock may run out, either because of local demand or such things as kind of delivery delays. So yeah, it's really tricky indeed.
Yeah, thank you. And I know that pharmacists have found it really tricky as well, because as people have been going in saying, you know, have you got my medication? If not, when will you have it? And very often the answer they get is, I'm sorry, we actually just don't know. And so I think it's been tricky all around, and have to acknowledge that everyone's managing this kind of difficult situation as best they can. All right, so next question also for you, Hughesy. How does the special authority process work?
Okay, so I think you gave me a really kind of patsy question up front, and now you're just like hammering me, Sarah. That's yes. So this is very exciting. So look, there is quite a bit of confusion about what the special authorities do. For Pharmac, they're very much a funding tool. Yeah, so they help Pharmac to ensure that medicines, certain medicines, are targeted to patients who would benefit most from them. And it usually sets out specific clinical criteria that must be met before a medicine can be funded. Across the whole range of medicines that Pharmac funds, you know, thousands of medicines, about 5% of those medicines are subject to a special authority criteria. But that 5% of medicines makes up to about just under 50% of our medicine spend. So we really do use the special authority to focus and to target patients and conditions where there is high need, high cost, and high demand. So in the ADHD space, there are four, to make it even more confusing, there are four special authorities, two for methylphenidate. So as I said before, SA2411, these are the first line treatments, Ritalin, Rubifen, Tiva ER, and the amazing new Sandoz brand. And then there's the SA2450, which is for the higher cost Concerta and Ritalin LA brands. There's also a separate brand, special authority criteria for lisdexamfetamine and dexamfetamine.
Right.
Does that make sense?
Well, it does make sense, but I know that people find the special authority question really difficult to understand. And I wonder if a fair follow-up question to it might be around the new medication. So anyone who is currently not able to get their methylphenidate that they have been using, if they did want to switch to the new one, the Sandoz XR, is that what it is? Will they need a new special authority?
If they've got a special authority for the Tiva ER product and they're on the Tiva ER product, they won't need a new special authority for the Sandoz special brand.
Great. And so just to complete that, if they were wanting to switch to lisdexamfetamine or what's known as Vyvanse, that does require a different special authority.
That does indeed, yes.
Okay, thank you. So anyone else have any comments on special authority and how that works? I wonder if Dr. Chin, did you have any comments on how special authority works in your context?
I can comment. I think Kara's raised her hand, so I'll go to Kara first, and I'll follow
okay.
up if there's anything else, Kara, that yeah.
I was just going to say that first of all, switching to lisdexamfetamine is a decision to be made with your doctor or your prescriber. So that one isn't as simple as just getting a new special authority. But if you're on methylphenidate and you need a new special authority, this is something that your community pharmacist might be able to help with as well. I know a lot of community pharmacists will communicate directly with the GPs or the prescribers just to help that process and help help you guys out getting that done. So if that is something that you have trouble with or is confusing, just speak to your community pharmacist and they'll be able to help with that too.
It's
I
really
would
helpful.
definitely endorse that, Cara. And I'd also say, I think one of the messages we've had from Pharmac in terms of prescribers is that given the shortages and given that within methylphenidate we have 2 different special authority numbers and the stocks of one or, medicines in one or the other can run low, it's not unreasonable to apply for both when you're starting methylphenidate, which can make it so much easier for, say, your primary care practitioner to help with that switch. So you wouldn't need to go back to the specialist to get a new special authority number.
Right. Okay. Oh, David Husey is back on with his hand up and his mic off. Your mic's off.
It's back on now, sorry.
Yeah.
But yes, swapping between brands, even those brands that are very similar, extended release brands, for example, should be approached with caution and a discussion with your prescriber. That's indeed the message we want to give. However, Pharmac wants to reduce as many bureaucratic hurdles as possible. Now, I know people will find that difficult to believe, but we got the removal of the special authority renewal process gone last year, and look, it still makes me happy thinking about that. So yeah.
Yeah, look,
Right.
I'd really echo that from a clinical perspective. I mean, you would think that methylphenidate is methylphenidate is methylphenidate for a lot of technical reasons that are probably too long-winded for this kind of conversation. They're not. That's the simple answer. And so you have to almost treat each one as a new medicine. Although, I mean, the guidance that's gone out to GPs is about choosing the most equivalent based on the kind of profiles, the so-called pharmacodynamic profiles to the medicine that a given person's on.
Oh, Kyra.
Yeah, I might digress just a tiny bit if that's okay, just to kind of try to clarify what we're all talking about with methylphenidate not all being the same. So the tablets and capsules that methylphenidate come in, they're really sophisticated, and each of them, they kind of release bursts of methylphenidate during the day. But all of the different formulations, they all release bursts in different ways and at different times. So, for example, Ritalin LA will release one burst of methylphenidate not long after you take it, and then another burst kind of 4 or 5 hours later, thereabouts. Whereas, Concerta, it starts off releasing only a little bit at the start and then kind of builds during the day. So it has a much bigger burst kind of early afternoon. So they're all really different. And switching brands, it may not, it might be the same dose. So you get the same amount. But if it releases those bursts at different times of the day, you could still feel that difference. So that's what we want to say about, switching between brands, and every switch, it does need to be discussed with maybe your pharmacist or your doctor or
That's really interesting. I think a lot of people do just think of it as brand names. So it's really, really good to get that information. And Kyra, you talked about what pharmacists can do to help. So with people talking to their community pharmacist, if their usual medicine isn't available. So that was really helpful. I wonder if there are any other views about potentially what GPs can do, or anything else that people can do if their usual medicine isn't available. Dr. Chin, do you have any ideas about what your patients might do?
Yes, I can. I can link back to a couple of the other answers, really. I mean, first, David Hughes spoke about the different stock levels within different pharmacies. And I spoke to the pharmacist across the road from our clinic earlier on today a little bit about this. And, some pharmacies are visited by far more people than others, which means the stock can run very low in some. And for the one down the road near our train station, they can have stocks for weeks longer than the others. And so really ringing around, and which does not sound a satisfying thing to recommend, But ringing around and seeing where the stock lies can be a really helpful thing to do, because you can find pools available. I guess the downside of that, of course, is if you are often picking up from different pharmacies, it means that you haven't necessarily got that one-to-one relationship with a pharmacist, which you might want, right? And especially when you're trying to deal with complicated changes. So I think there are pros and cons to that. I think the other thing I'd suggest is that, say, for example, there's the GP. If we have both special authorities for methylphenidate ticked, that would open up the whole range of different medicine options there, which means they can, in consultation, think about what's the best fit. So if the one you've been taking, which has presumably been working well, is not available, what's the one that maps best onto that? So having a discussion with them about that would be useful. But I can see David and Kyra both chomping at the bit, so I'll hand over.
Thank you. Should we go to David?
Yes, look, I mean, my comment also was in these days of electronic prescriptions, I think it's really helpful to ask your GP for a hard copy, because that means if your usual pharmacy doesn't have it, you've got that hard copy to take to a pharmacy that you find does have the product you want.
Yeah, very practical advice. Thank you. Kyra.
Yeah, so I really just wanted to say, like what David Chin was saying about shopping around and ringing different pharmacies to see who's got stock. That is absolutely a good thing to do if your normal pharmacy doesn't have any. But ideally, having a single pharmacy that you go to as your pharmacy and having a relationship with that pharmacist will really help. And we know that have that same pharmacy. So then the pharmacy is kind of expecting a prescription for you every month, and they know what you have. So if they have stock and you're a regular person and have regular scripts, they might keep it for them, keep it for you. I know a lot of pharmacies that will kind of reserve their stock for their regulars, and only give any extra stuff for the people that are shopping around.
Yes, we have heard about that as well.
Yeah, but also, we know there's a lot of people out there do perfectly fine switching between the brands, but we know there's a lot of people who really, really struggle with that. We know there's a lot of young children that really struggle with the changing between brands. And if you do have these particular challenges, speak to your pharmacist, because if you're finding it more difficult than others, they'll help you out as much as they can.
Thank you. So one of the issues that some people are facing with not being able to get their medication when it's prescribed is that script that you might take away the hard copy, or it might get sent over to a pharmacy, it only lasts 7 days. And so if you can't get hold of your medication within the 7 days, then you've got to go back to the GP and say, can you please issue me another script so I can give it another try? And some people are going through this week after week and finally stop asking because they feel they're making pests of themselves. But also it seems that some people are being charged every time that prescription gets issued. So every 7 days paying the $25 or $30 that the GP charges to issue the script. Should that really be happening? Should we talk to David Hughes?
Yeah, again, great. Look, really good question. And obviously I don't have any influence on how primary care funding is structured. But yes, that does seem unfair, doesn't it? And you could argue that that repeat prescription could be waived. Yeah, but I do know that working closely with your usual prescriber, it's really important when you have to change these meds. And as Kyra said, switching between brands can be complex, and the systems, the different tablet formulations can have different release profiles. And that's fine if you're on a blood pressure tablet, you won't notice. But if you're on something that you're just very aware of, then yeah, it can be very distressing. So the best person to talk to is somebody you know well, whether that's, as Cara said, your pharmacist, or say the person who usually prescribes your medicine. I mean, yes, whether they've got some wiggle room around that kind of the fees that they charge, it wouldn't, you know, what could you? They could only just say no, couldn't they, if you asked?
Yes, I
You
suppose
know?
that's when we're dealing with the business end of the GP practice.
Yeah, yeah.
Could I go to David Chin for the next question? It's a question about children and adults coping with changes in brands, and does that mean sometimes that they might be having different pill sizes or a different number of pills that they're taking each day? And for some people that might be challenging. Are there ways that that people can be helped to deal with that transition and still take their medication safely?
Yes, no, that's again another great question. I mean, I think we've spoken a little bit about changes within the methylphenidate brands, and I would agree with the other panelists to say that for some people they wouldn't notice much difference between them, but for others it can be really devastating, especially for young children who may have had a really good, you know, efficacious, tolerable regime on one. When switching to another, things can really be a lot more challenging. We usually use methylphenidate. There's evidence to suggest that we should use that preferentially for children and dexamphetamine preferentially for adults, because methylphenidate is better tolerated by children than dexamphetamine, although both are useful, you know, efficacious medicines. So I guess I'm thinking particularly about children and young people in this context. I think if you have had to change brand, there are three things I guess I'm watching out for as a prescriber. I guess I'm watching out for logistics, as you mentioned, Sarah, in terms of the number of pills. How easy is it to swallow those medicines? I mean, some of the ways around that, the immediate release medicines can be crushed. You can crush those because you're not depending on any extended release profiles, which can sometimes make it easy, especially for young children who may have real difficulty swallowing tablets. The other way to get around tablet swallowing difficulties can be the Ritalin LA capsules. Have crystals inside. You can break open the capsules, sprinkle them on a spoonful of something soft and palatable, and they can have that. So that's one way of getting around the swallowing difficulties. I am also aware of a product which I've never used, but I've seen advertised in the last year. It's something called Gloop, G-L-O-U-P, which has been predominantly advertised for the psychogeriatric population in terms of having difficulty swallowing pills. But it's like a gel. You can embed a pill in, and sort of that coating makes it a lot more palatable, apparently, to swallow. I know it's used in Australia, but I haven't seen it used in New Zealand. But it comes in some very enticing flavors. So anyway, I think about logistics. I'd also think about tolerability. So looking out for the side effects, because whilst one brand of methylphenidate may have been tolerable, others may not be. And particularly for young children, I'm thinking about appetite and sleep. Those are the two things I'm generally watching out for first. And lastly, efficacy and how well does it work? Does it work? And if it does work, how long does it last for? Is there a significant rebound after the medicine wears off? So I totally agree with what the other panelists have said about if there is a change, communicating with the pharmacist and your prescriber, because it may be possible to fine tune a lot of things with that change.
Thank you. And Kyra, I imagine that you're aware of pharmacists seeing this a lot and noticing that patients are getting new prescriptions and having to give some advice around that.
Yeah, for sure. And one really important thing, because, you know, I was saying that the different brands of tablets release kind of bursts of medicine at different times during the day. So if you do switch to a new brand and you find it doesn't suit you, it's really helpful to take notice of how it doesn't suit you. You know, are your symptoms just not as good throughout the whole day? Or are there particular times of day that aren't helpful? Because it may just be that burst of methylphenidate's at the wrong time with that brand. So the more of kind of that information you can give to your prescriber and your pharmacist, it really helps with that brand selection. So it's really helpful to take notice of those things.
Right. And I imagine there'd be a bit of switching and then switching back then, because some people may find that when they do try a new medication, it just doesn't work for them. Is it easy to just go back to the previous one or try a third one?
Yeah, you should be able to go back to the other one, because methylphenidate, these tablets are made so that, you know, the methylphenidate doesn't build up in your body day after day. It's kind of in and out in the same day. So if you take one brand one day and then a different brand the next day, that should be fine, you know.
Right, thank you. So finally, let's go to Marinda for our last question. Marinda, this is the hard one. When will the shortage end? And what are the plans to deal with future demand?
Sarah, like I said, we are continuing to work with all our suppliers to see that how we can increase or at least maintain those levels that is needed, but also how we can increase the quantities that come into New Zealand for that increased demand. We have funded a new medicine, lisdexamfetamine. That's already, the Vyvanse already funded. And as you heard in the beginning, we are bringing another product on board from the 1st of December through Sandoz. And then we have delayed the changes in prescribing to February to give the system, the health system, time to kind of catch up and prepare for it. So the timeliness of Sandoz coming on board is one of those things that help for that. I'm unfortunately not able to tell you tonight that this is the end of the restriction in supply. We expect that will continue through into 2026, but we keep on monitoring the demand versus supply and actively working on it.
Great, thank you. Does anyone else have any comments that they'd like to add on that question? No, okay. So in that case, I think we're going to go through to some questions that have been coming through. Technical issue perhaps, Anna, is I'm not seeing the questions yet. Just give me 1 minute, it'll be right there.
I can see one question in the chat, which might be for you, Husey, asking why Concerta and Teva have different numbers, different special authority numbers. You're on mute again.
I'm on mute again. Why do they have different special authority numbers? It is simply this: one is more expensive than the other, and as I said, the special authority is around funding and targeting funding. So it is, if you look at the way that special authority is worded, it is for people who have experienced challenges on the first line treatments. So we are looking to keep those more expensive medicines as a second line for those who've had challenges on the first line medicines.
If I can just add though, and it's not to do with the special authorities, but Teva and Concerta are not the same. Teva is probably most like Ritalin LA, and at least on paper, it looks like finally in terms of the Sandoz product, we do have an alternative to Concerta that is actually equivalent. So that's why I think it's great that we do have finally an alternative to Concerta, which has been the outlier in terms of it being difficult to find an equivalent if that's what suits a person.
Just to clarify, sorry, just to clarify, the Teva is most equivalent to the Rubifin SR.
Oh, okay.
Yeah, sorry.
This is a somewhat controversial topic, David, but I think you're right. We are very pleased to have the Sandoz product. Ashley tells me it's got the Oros.
Yes.
Not sure if it's a single layer or a double layer, but Kyra no doubt can give us a brief lecture on the Oros. So the way that the tablet disperses. So yes, let us see how that works out in real life.
So just a follow-up question to that. I know that this will be really important to a lot of people. Where can people find that information about which ones are most equivalent to others?
So, I mean, there's been a lot of effort from Pharmac's end put into communicating with GPs the different profiles of these medicines along the line that Kyra described earlier, and so that they have a basis then to decide for a given medicine what the best alternative will be. I mean, it is literally based on the different ways that the drug is released into your system. Some are more rapid, some are slower, some are in the middle, and depending on a whole raft of factors, for some people it's the more rapid release that works better and lasts as long as they need. For other people, the middle suits, and there are others where the long acting is what suits them. But then there are people for whom immediate release works, who long acting will go on too long for example. So it's a matter of finding the nearest equivalent in terms of the way and duration of its release into your system.
Yeah, so talk to your GP, because your GP probably has all this information. It does sound like an opportunity for a really nice visual that could be produced for people to get that general understanding as well. Sorry,
Yes,
Kyra, did I see you with your hand up? Yes.
We are working on something. We're putting together again, a professional development pack, so for general practitioners around these very things. So yes, and we have in mind a wonderful visual tool to help general practitioners and other prescribers.
Dare I say, David, though, it might be good to have a version for the public as well, so that they at least come in able to have an informed conversation.
Yeah.
Yes, that indeed would be good.
That's what I was going to say. I think something like that, and maybe you could go on the ADHD website, that visual that shows, when each of them release their medication. So
yeah,
I think that
I
would be
think that
really
could really
useful.
assist with those conversations with the GP and people coming in prepared and understanding what that's likely to involve.
Yeah, and why they have a bit of a dip in the middle of the day, which they didn't have before, or something, things like that.
Yeah.
We will work hard on that.
So there's another question that's come through. It says, I work in a GP clinic. Is it helpful as a patient to have a text notification from the clinic inviting you to make a GP appointment if we see that your brand and strength is currently out of stock? But if I'm not wrong from what I've understood tonight, your GP would not necessarily know that your brand and strength is out of stock at the local pharmacy.
True.
I'd say so. I think it would be, and unless you've got a combined clinic, I think it would be difficult for them to be aware of that.
Yeah. Okay. So the onus really is on the patient to say to the pharmacist, can you please contact my GP, or to contact the GP yourself? And GPs are operating without really knowing what's out there and where it might be available. So the next question is, can the special authority information be provided visually, like a table outlining what comes under each of the 4 different special authorities? So again, more requests for ADHD people love their visuals, helping them understand how all of this works. What are the different special authorities for the different types of medicines? And most people wouldn't know what special authority number they have.
Indeed. Look, while we are talking, my team is frantically designing a table with those things on it. It hasn't quite come to fruition yet, but yes, thank you for that.
I can see in the chat actually Kyle has popped one he's already made into the chat,
Nice work.
which is a really nice synopsis of where the ground lies right now.
Nice. AI might be helpful too in this.
It'll be interesting to see how people use it once they have it, of course. Okay, next one says, thank you to all of you for the really helpful information about access to ADHD medications. The question is, given that Pharmac has already reviewed the evidence showing that micronutrients can be efficacious for ADHD, when can we expect those treatments to be funded by Pharmac?
Yes, that's a really good question. So as far as I'm aware, there is not a current provider of a MedSafe approved product that we could fund through our schedule. And yeah, that does make it very difficult. And so things have stalled indeed. So yeah, but it is a watch this space.
Yeah, I think a lot of people have got the awareness of the micronutrient formulation that's been developed here in New Zealand. There's been a lot of research around it in New Zealand. So what you're telling us is that it's not approved as a medicine. And until it's approved as a medicine, then Pharmac can't consider it for funding.
Indeed, it's very tricky.
If I can just give a clinical perspective here, I mean, actually, there are a group of people who they work quite well for.
Yeah.
And there are a significant group who they don't really. And so I think that that's the reality with them. And certainly they are relatively expensive. I mean, there are,
And I know for young people, one of the challenges I think that they are working on is the administration as well. Until recently, you needed to take 12 capsules a day, so 6 in the morning, 6 at lunch. And I helped a number of young people start them and never had anyone go past 4 months on the micronutrients. But they are looking at other formulations that are much less logistically challenging that are encouraging. Because I agree with both Davids that there is some encouraging data around these, and I think that's likely they will become more and more part of the landscape.
Well, here's hoping. Next question, is it possible to prescribe in such a way that allows Teva to replace Concerta given the different SAs, so special authorities? The person asking this question says, I was under the impression that Teva was the closest replacement to Concerta.
Yeah, look, we're in controversial territory here.
Yes.
And look, yeah. So is there? Yes. So because we're very aware of Concerta and the Teva product, having kind of each of them gone into supply issues. Yeah, we're open to prescribers to apply for the other special authority.
Dare I say though that up till now, Ritalin LA has been the better alternative, and that's the same special authority. The complication now is that if on paper is what it looks like, actually it's Sandoz XR that is actually the closest and is a different special authority. So, yeah.
And so we do know that a lot of people who normally use Concerta have been going to their pharmacy to pick up their medication and get offered Teva. And so that would mean that they do have both of those special authorities. Is that correct? So that would be one way that you would know if that's ever happened to you.
Yeah.
And a lot of people switch between those two perfectly fine.
Yeah.
And don't notice any difference at all. But yeah, they do release the methylphenidate slightly differently, so some people will definitely notice that. But yeah, as David Kadaya was saying, this new formulation, the Sandoz one, it does on paper, as you say, it does look to be very similar to Concerta. So we'll be personally, I'm looking forward to hearing the reports from people that take it. So
yeah, and actually there's a good comment here that I thought I would raise, because although it's not a question, and it's basically people who work with families and children that have ADHD. So they might be counselors or ADHD coaches and others who are not prescribing and don't have this knowledge of the medication. The comment is that it would be really helpful for them to have this as well, because they're talking to parents and talking to children and young people and even adults with ADHD about how to manage. And so if they had this awareness, then those kinds of conversations about, having a big lull in the middle of the day or something like that could take on a whole other meaning, where, people might be encouraged then to talk to their GP because there would be this other explanation for it.
Actually, I mean, that has indeed been happening. I mean, there's been a real upswing in interest and attendance from a range of different professional groups into the professional education relating to ADHD delivered by people like Goodfellow Unit. So it was really interesting. There was a Goodfellow webinar earlier in the year, and if you look at the attendee list, it wasn't just GPs and nurse practitioners. It was a very wide group who have interest in this area, which is great to see.
This is, I think in a way, this shows the difference with ADHD. You know, people with ADHD do often tend to be details people. You know, we like details more than maybe other groups do. And yeah, maybe we do need to respond to that better and provide more of that detail. We just don't want to make it too technical and sciencey, but yeah, definitely more detail. We can do that.
And I guess I've just point to one other, a bit of shameless self-promotion. One other point of information is my team, we've been running ADHD training days once a term for the parents and caregivers of children and young people who've been diagnosed with ADHD, open to anyone in the country for free all day. And we run that 4 times a year. And if anyone is interested, you know, contacting Sarah, I'm happy to pass the details on. Very happy to include anyone who's interested in being part of that. We go through some of the graphs we've alluded to during the talk today.
That sounds fantastic. Well, I think, you know, we've learned some really important things from the conversation tonight around that, you know, there are lots of things that can be done to help people deal with shortages and to help people transition to different medication if that's going to work for them, and that they need to be talking to their pharmacist and talking to their GP, and thinking about how that could work for them with different solutions. Having some new medication coming on board is another option to try, and that people shouldn't be worried about the difficulty of transitioning from one medication to another and being able to transition back if needed, and that clinicians should really be supporting that. And the other thing I think that's come through, you know, quite loud and clear here is that there's a lot of really interesting information about the different medications that people aren't aware are actually significant differences, that it's not just branding. And so there's a bit of education that needs to happen, with a bit of each of us having a personal responsibility to educate ourselves, to ask the right questions, ask the pharmacist, ask the GP, and for those of us who deal with the community or deal with patients, to make sure that we're helping them understand this information as well. So I think that was all of the questions that we got through this evening. So I just want to say thank you to the panelists for answering all these questions tonight. Again, we will, if anyone has asked a question and somehow we've missed it, we will pass them on and we will make sure that we get those answers available to everyone. And this will be posted on Zoom as soon as, on YouTube, as soon as we've finished with the edits that we need to do. So thank you to the audience as well for taking the time to join us, and to everyone who's shared their questions this evening or through the Ask Pharmac campaign that we were able to use before we got started. Thank you to all the panelists for sharing your expertise. So keep an eye on the ADHD New Zealand website and social media channels over the coming weeks for the captioned recording and the answers to the questions that we didn't get to. One last hand up, Kyra, before we go. Final comment.
I was just looking in the chat, and there's a release chart of the different medication types, and there's a little bit of debate about whether it's accurate. I've had a quick look at it, and it isn't really what we think is happening with these different medicines. So we will try to get something better onto your website, so that something that we know has been through the big checking machine. So.
Fantastic. Reviewing the evidence in real time for the audience tonight. Thank you so much. All right, thank you everybody, and really, really grateful for this, and I'm sure that there will be a lot of value, and many, many more people will tune in to watch this later on than those who were available for it tonight. Thanks everyone.
Thank you.
Thanks everyone.
Bye.
Bye.
Bye.